guys ready? You guys ready? Okay, let's go ahead and get started. I want to welcome everyone to our DMICE Thursday Research Conference. And on some of these conferences, we sort of have special conferences. So today is one of those days, the Informatics Discovery Lab, which is headed up by Dr. Aaron Cohn, one of our faculty who actually is unfortunately way out of town at a conference, can't be here today. But we'll be hearing today about one of the major projects of the IDL, which is their work with the Knight Cardiovascular Institute in helping to develop a data analytics capability. And we'll have 4 presenters who I'll introduce in a moment. But first I have some housekeeping. One is for either people who are here, physicians who are either here or listening online and want continuing medical education, CME credit. Lynn will be sending out a SurveyMonkey link so people can sign up to get that CME credit. Also want to just announce some upcoming dates. Actually, a week from today, our speaker will be Dr. Vinay Prasad from the Knight Cancer Institute. If you've read about him, you've read it like in the New York Times, whatever. He's done a lot of interesting work around conflict of interest in clinical trials and things like that. So he'll be here next week. I would be remiss if I didn't remind everyone about October 28th, and actually the 27th for the fellows. Dr. Patty Brennan, the new director of the National Library of Medicine, is coming out. The BICC will be celebrating all day on the 28th, our 25th anniversary of the building. Some of us were here then. And some of the originators, the people who got the BICC when it was a center started, will be here and speaking. Dr. Don Lindberg, who was the director of the NLM for many years. And then the keynote talk will be Patty Brennan, and starting at 1 o'clock in the afternoon. And then there's actually going to be an open house all through the building. And so everyone is invited to attend. And there's also, I heard, a good speaker on November 3rd. But I'll let you guys figure out who that is. Anyways, let me introduce our speakers today. Dr. Mudd's not here. Okay, so I'll start with the rest. And I'm only going to read this briefly, because if I read everything they sent me, you wouldn't get to hear their talk. So first we'll hear from Greg Lampros, who is the Clinical Department Administrator for the Knight Cardiovascular Institute, and has been working with our team, Aaron and Nicole Weisskopf, who I'll mention in a moment, to develop this health quality measurement data analytics capability for cardiovascular care, which is an important priority of the Knight Cardiovascular Institute. He's also part of the Knight Cardiovascular Institute Executive Clinical Leadership Team, manages cardiology clinics and outreach services and a number of other functions. He will be joined in this talk by Anindita Bagchi, is that how close enough? Who's a systems application analyst in the clinical informatics department in the hospital and works primarily on Knight Cardiovascular Institute projects. And then the third presenter will be our own Dr. Nicole Weisskopf, who's an assistant professor in the department and is involved in the Knight cardiovascular projects and also has an interest in data quality. And if he comes, we'll also hear from Dr. James Mudd, who's an associate professor of medicine in the Division of Cardiology and director of the Heart Transplant and Advanced Cardiac Services program. So I will not take up any more time of our speakers. So you need to put this on. It's mostly on for capturing, because we don't really need a microphone, but yeah, up high, I'm told, and then you can do this.
So I'll be a little bit out of order. I was supposed to be second, and so I'll just run down to my slides here. And my background is in both clinical patient care and in operations, and then I get my informatics and analytics from a career in industry where I used analytics in trading futures and derivatives to position cash flows against large production inventories. And back then, analytics wasn't, I put my first motherboard together. You got them in the mail and you press the little chips in the board, and developed our own systems there and used to write little programs to help unwind and wind our positions. But the Chicago Merc Exchange at the time was probably pretty futuristic in that we could have a number of monitors on our desk and we could watch the market move in real time. That was back in the 80s when that came about. I drove my first graph, the XY axis with a quadratic equation when I was a senior in undergrad school. In my time, you had to take a class in the slide rule if you were a science major, and I was really good with that at one time. I can't even add or subtract on it now, but at one time I was pretty good. So I go way back in how data is used in mathematics and things such as that. So for me, what I brought to the table is the visualization of data, since that's sort of where I cut my teeth, and predictive analytics, used to build some predictive analytics programs back in the early 80s that would predict market trends and future positions of the commodities that we had to deal with based on political, economic, and social reforms that had happened in the past and we thought were currently in place in the future. And we use those models quite a bit in our trading decisions. So we use data to make decisions. And so when I came to healthcare, I didn't see a lot of that going on. I didn't see the data within medicine was being used in that type of manner where we would visualize the data and then predict outcomes. And the market started to change not too long after I got here, about 9 years ago, in that the government, and currently with the Affordable Care Act that just happened a few years ago, started to put more pressure on institutions to reduce their costs and improve their quality. And so they came out with a number of programs, and let me just skip to that real quick. And these are some of the names of them. MACRA is the newest one. Bundled payments, population health, you may have heard of, and value-based purchasing. So value-based purchasing was one of the first, and that was mainly the payers were going to purchase the value of your outcomes. Or in other words, they're trying to make sure that you had improved your patient outcomes and met certain metrics that you could prove that you were providing better health care. And if you did, then they would reward you accordingly, either with a positive increase in your payment or a negative decrease in your deduction. So the objective of this was to, I shouldn't say push, but move physicians and healthcare systems into a new world of financial accountability for quality and cost for patients they care for. And the newest MACRA is sort of, I would say, bundling a lot of this together, but what MACRA is doing is it offers multiple pathways with verifying levels of risk and reward for providers to tie more of their payments to quality. So instead of just fee for service, you're going to be paid more on your quality outcomes and how you improve actually the overall health care of your patients. But you need data to do that. You need metrics to present to show that that happens. So in this system, the physicians are scored on 4 metrics. Quality is one, which is what we're talking about today. Resource use, clinical practice improvement activities, and meaningful use of the EHR, electronic medical record technology. And then based on those, you can earn as much as a 9% incentive or as low as a 9% deduct from your payments from CMS. So with this changing landscape, we've also have bundled payments, which means that if a patient comes in the hospital for 90 days after, no matter where they go after, you're accountable for their care. So even if they're admitted to another hospital, if they're admitted to a rehab unit, where that bundled payment says, here's so much money to take care of this patient for the next 90 days. Whatever happens to them, you're accountable for that care and the cost of that care. There's a lot more to it than that, but just quickly. Population health, which is where this analytics really comes into play and what we've done, is part of that bundled payment where we can actually start to manage the population, not just within OHSU, but across the system and across the state, so that we're actually improving the health care of all Oregonians and not just those who come to OHSU. So their goals are clear and organizational focus around quality, safety, and service, which I've somewhat mentioned, optimization of outcomes through standardization and efficiencies, cultural integration among providers, which right now is including a cultural transformation. This is a lot to add on to providers' plates from what they've already had added on, and just defining these. For example, the macro document's almost 1,000 pages. The government's really good at making big, thick documents to explain what they could in about 5 pages, but that's how big it is, and et cetera. And of course, expectation of clarity of purpose and expected outcomes, which is, again, where analytics comes into play. So our objective with this project is to standardize heart failure care, so we focused on that disease. There's a number of them, but it was heart failure we started with at and beyond OHSU. And we want to move beyond just treating heart failure to building an analytics architectural platform that can set the goals, build the plan, design the workflow, and communicate results that can meet the demands of value-based purchasing healthcare market. One of the things that started this was a few years ago, Dr. Joaquin Figueroa came to me, and we were just starting with this program called Meaningful Use at that time, and we were getting certain metrics, and he was looking at his data that I had sent him, and it showed that based on a metric around aspirin and providing aspirin as a therapy for patients who have had myocardial infarction, his was not 100%. And he said, that can't be. I always do it all the time. It's 100%, and if not, there's a reason why. So he asked me to look into the data, and we couldn't really find why the other piece wasn't there, only that he met a certain percent. And so we started to look further into it, and he said, well, we need to take a disease state and look at the whole disease state and see what the metrics are that were required, which at the time were the American College of Cardiology metrics, of which there was 9 metrics, and how we perform against them. Because of what was coming down the road and all these new demands that are coming from the government, payers are lining up behind them, and they're saying, if you don't meet these metrics, we're not going to pay you for all your services. And so we needed a way to say to the payers, this is why we're not 100% use of aspirin for this certain condition. There's reasons not. If you're on another blood thinner, you wouldn't prescribe aspirin, for example. And so we started to think about this. There was another person in our department, Yuri Sklener, who's a PhD software engineer, and he and I got together and started to pull data and found out that we needed a lot more brain power and support than what just the two of us could do together. His brain power is a lot bigger than mine, but I certainly needed a lot of support. And so we got together with DMICE and developed a collaboration between us to look at these metrics and find a way to source the data, validate the data, and then put together a visual graphing program that was real-time and could provide our providers with the information they knew to see how they were doing on these 9 metrics. Now, we focused on outpatient because inpatient's a little easier to do this. Nationally, 67% of inpatient patients, when they leave the hospital, there's documentation that they're meeting these metrics. On the outpatient side, though, which is most of their world, only 27% is documented that they're meeting the guidelines that are set aside by the American College of Cardiology. So that's where we focused because we needed to show payers and CMS that we were meeting these metrics across the system, not just inpatient but outpatient, and as we go forward across the state. And so this type of work has to move into more with our partners like Salem, Tualatin. We're working with Mid-Columbia on some of these things up in the Dalles, and so that we can show that our patients that come to OHSU and that are in our system are getting the proper patient quality care. So I guess I could go back a little bit and talk about Dr. Mudd's piece on this. Not as eloquent as he is on it, but he's on rounds in the hospital, and right now he's probably caught up with some patients. But as he noted, well-intended healthcare teams can become overburdened with a complex system and unintentionally deliver substandard care. And we know that iotronic causes of death, or if you were to line it up as a disease state, it falls under heart disease as number 1, cancer is number 2, and it would be number 3 in the number of deaths. And so it's a big concern with the healthcare system. And as he noted, it's often due to the complexities of the healthcare system and overload of actionable data streams. And so what he wanted to look at is how can we best leverage the EHR to identify patients and deliver guideline-recommended quality and value-driven patient care, which is what this project is about. He noted that in the U.S., 6.6 million adults have heart failure. There's 875,000 diagnosed with the age over 45, 1.8 million office visits in 2010, and that's gone way up since to 2016, and over 1 million hospitalizations annually from 2000 to 2010. 25% of those are readmitted within a month, and 50% are readmitted within 6 months. So these are multiple readmissions. One of the metrics for Medicare is that if a patient has a diagnosis of heart failure and leaves the hospital and returns within 30 days, we pay the bill. They won't pay for that, with the idea that we were supposed to do better in their follow-up care after they left the hospital so they didn't return. So you're not going to prevent all of them from returning, but again, we've used data to track length of stay and a number of other measures, their risk assessment and their case mix index, et cetera, to determine, and documentation, what we need to do to make sure we're following up. And some of these are, again, came from visual analytics, and we've hired different people because of what the analytics have shown, who now sit more in a transition phase to make sure the patients are following up with their appointments and that the care management is being appropriately given to them in their homes and they're returning to the clinic. A lot of them get lost. They don't return to the clinic, and where they return is the emergency room. Then they end up in the hospital, where a lot of their conditions could be evaluated and taken care of prior to that happening. So it's a $30.7 billion total cost for heart failure, $69 billion in 2030. For cardiovascular care in total, that's stroke, et cetera, and the vascular system, the estimate is that it will cost this nation $1.2 trillion in 2030 in healthcare costs. That's up from $287 billion in 2010. So it's a real issue in our population. It's a Western disease, so to speak, and it's something that we have to get our arms around as a nation because of the costs that are associated with it. And it's the most common cause of admissions of patients over 65, and the largest contributor to $17 billion spent for unplanned readmissions. So these are readmissions that weren't planned and that come back through the emergency room. There's a 35% survival 5 years after hospitalization, independent of the ejection fraction, and this chart shows over time the survival. What Dr. Mudd would point out is that once you're diagnosed with heart failure, that's a lifelong condition. You get recovered through that with a heart transplant. They have certainly left ventricular device, or LVADs, that will keep the heart working until transplant, or what we call bridge to transplant. But once it's a disease that's there, and unlike many types of cancer that are curable, and you may not ever go back into readmission, this one's there, and the main thing that the medicines do now make it so it's more livable for the patient, and they can live a more productive life than what they used to do. So that's where medicine has taken it this far. So it's quite a concern. And if there's those of you who are physicians, you can correct me if I'm wrong on some of this, feel free to. But, this is the projected cost, as he talked about. You can see the prevalence from 2010 to 2030 is up 25%, but the direct costs from the same time will rise 215%. So that's what is costing the nation or will cost the nation. The quality metrics that we looked at on the outpatient, I mentioned 9. There were 6 that we primarily focused on. Stage and functional classification, systolic function assessment, and that was a really difficult one on a data basis to acquire and validate. Did a lot of chart review, Nicole and her team. And symptom assessment and management, patient self-care education, medication prescription, and counseling about implantable devices. The patient self-care education is a really important one, and if we look at a heat map, we can see all our patients individually, their appointments into the future, and we can see whether they're meeting these guidelines or not. So that's a heat map we've developed. Faiza Khan has developed that heat map, who's part of our team. And so we're able, and what we've seen, the reddest part of the heat map is red and green, is in patient self-education and implantable device counseling. And we found out it's the patient that can care for themselves the best, that are the most educated, that have the best outcomes with heart failure, or truly with any disease. And so we're able to then look at the heat map and get hold of these patients and have a caseworker start to work with them on make sure they're educated on how to take care of their disease proactively. So I'm not sure what this one is.
So this is a very simple example of the kind of patient that might come to OHSU for heart failure treatment. He's here for his second appointment, which is when a lot of these quality metrics kick in. And he was diagnosed with heart failure by his primary care provider, who also started him on a beta blocker due to his reduced systolic function, which is appropriate. But in this specific case, he was prescribed a beta blocker that is not actually one of the evidence-based medications. So what the OHSU provider would want to do at this point is get them onto one of the evidence-based medications, but it can be difficult to, we need to find better ways to present that information to the provider and make sure that it's actionable.
Okay, right. So as some of the bullets he's put up are what phase of the disease are they in, and are they receiving the correct interventions, and how can we leverage the EHR to make clinical actionable and usable, and then monitor it over time, which was part of our project. So why does standardization matter? Consistent application of evidence-based therapies, and here's Dr. Mudd right now. So I had rolled into your part of your presentation.
That is fine. I apologize. Procedures never go as planned. You can come and go ahead. I'll show you. You can see up there as far as I have gotten. That's fine. I apologize.
If he is going to talk, can you give him the mic?
Yep.
Sure, thanks. I'm very sorry. So I'm Jim Mudd. I'm director of the Heart Failure and Heart Transplant Program here. And this has been a great journey together for this. So the challenge is that we as clinicians are we get hamstringed by a lot of things, and we think we're doing the right thing, but we don't always necessarily document it in the right manner. And what happened is we have well-intentioned systems, but poorly executed sometimes. And it's because sometimes we fight Epic, and we shouldn't really be fighting Epic. We should embrace Epic and use it to the advantage of the teams and the patients. So there's complexities of the system. There's really lots of data, and we're inundated with data. And the question is how to get actionable data. So how can we leverage the electronic health record to identify the patients who have the disease of interest or the condition of interest, and how do we deliver the therapies that they need? So heart failure is a test case. Well, heart failure is a problem, and this is some of the stats that maybe Greg went through. And the thing that we focus a lot on are the readmissions, 25% readmission within 1 month and 50% at 6 months. And the reason that's a big issue from readmission standpoint. Okay, I'm sorry. Well, I can talk about, did you go stage and functional class, Greg? Okay. So if we look at a patient here, we don't necessarily know what therapies they are getting. And the question is, are we getting them the right therapies at the right time? What stage of the disease are they in? And how can we monitor them over time? And how can we make the electronic health record clinically actionable and useful to be able to deliver the therapies that they need? And how do we monitor them over time through various clinical encounters and through various providers? Because not one provider or team of providers is seeing these patients all the time. It's multiple providers in subspecialty or in primary care. So the reason that this is important is because a lot of times we think we're doing the right thing, but we may not necessarily be doing the right thing. We're pretty good with the electronic health record and documenting medications, but that doesn't necessarily mean medication adherence. Similarly, we are not able to document some discrete variables that are clinically meaningful outside of medications. The nice thing about medications is it's there, it gets pulled in. That doesn't mean the patient's taking it, it just means you've prescribed it. Two very different things. We still know medication adherence, for example, a year after a myocardial infarction is only about 60 to 70% of the medications that we know that have an improved morbidity and mortality. So clicking buttons and prescribing things doesn't necessarily mean patients are taking it. But if we have a better way to monitor it, hopefully we can work on medication adherence with the various team members. And this hopefully will lead to improved morbidity and mortality and decrease the hospitalizations that, again, are a large part of that $17 billion that is spent on readmissions. And importantly, then you can resource the system a little bit better. One of the problems in medicine is we plug patients into the system, but maybe not when they need to be seen. And conversely, we're not seeing the people that we need to be seen. So how can we use the electronic medical record and the provisions of that to get the right patient to the right provider at the right time and reappropriate resources? We have a lot of resources that we think are efficient, but it's just a lot of waste in the system. And we have to be able to be better with that. So we need to know what's already been done. We need to find out what needs to be done. And we need to limit that documentation burden, and we need to have document in a discoverable manner. Right now we've employed drag and dictation throughout the institution, which I personally like. It's a great way of really being able to give a lot more dialogue to the care that you're delivering and the care that team's delivering. The challenge is it's not necessarily easily discoverable. You can do and you all know this better than I do, the natural language processing and hunt for things. But there are certain things we shouldn't have to hunt for. We should just open it up as a bin of ones and zeros and download it right away. And we don't necessarily do that. So that's the flip side, I think, of having dragging dictation across the institution. So we want to be able to have important salient features to the clinical encounter be able to be discoverable in a quick manner. Greg, did you go for some of this?
Yeah, I did that.
Okay. Again, I apologize.
Okay, so the informatics side of this is going to be split into two sections. So I'll be handing this off halfway through to Anandita. So let's return to our simple clinical example. And the question for us as informaticians is how can we leverage the EHR and other health information technology to help this patient and also patients like him? So one thing, we want to make sure that providers are able to tell if this specific patient is receiving appropriate care. We want to know if providers in general are following evidence-based standards of care. And lastly, we want to actually use health information technology to not just provide information, but to actually help providers improve the quality of care at the individual and the population level. So this is our picture of how we would like things to work. So this would be performance on one of these clinical quality measures. And the idea is that over time, through various interventions, we are able to take performance all the way up to this maximum benchmark, which ideally would be 100%. Sometimes that's not totally feasible. But what we know from past research and also our own experience is that there is a pretty big difference for some of these measures between observed performance and actual performance. And a lot of that is due to limitations in the data that we can access and the systems that we're using. So before we can really start effectively improving actual performance, we need to bring this observed line up to the actual line, because that way we can tell how we're really doing and we know what we need to address. Oops. So between the actual and the maximum achievable, we have care-related issues we want to address, but below that are the issues due to implementation and also data-related problems. So I'm not going to go through this whole thing because it's kind of crazy, but this is an overview of the process that we use in the IDL when we implement and validate a single clinical quality measure. And you can see there's work in interpreting these measures, identifying the data sources that we need, doing system development, the actual measure development, validation, and then synthesizing the results to make them actionable for providers and also for Anindita and her team. So there's a lot of collaboration, there's a lot of iteration, and overall just a lot of work. And this is one of the things that we get out of all this work. This is a visualization developed by FISA. These are the 9 ACC heart failure measures, and this is overall performance. We have various visualizations that drill down. So this is the overall KCVI performance. We can drill down by team. We can drill down by provider. And this is a report that is provided to decision makers and stakeholders on a regular basis. So we've gotten that flow of information to them. But when we do that, that validation, the in-depth validation we do, even though we have minimized the problems due to implementation, due to the CQM calculation system, we still have problems with the validity and reliability of these measures. This is kind of information overload a little bit, but the important points, so this is the LVEF measure. So just has a provider reviewed reviewed the patient's systolic function. So this is a pretty fundamental measure for heart failure. Our observed performance, which is that top left Venn diagram, is about 72%. Based on manual chart review, we know it's actually about 98%. So then we want to know, why is there such a difference? We're doing pretty well capturing the denominator population, which is based on diagnosis and number of visits and age. And then over here is the problem. This is the numerator. So these are the patients who have had their systolic function reviewed. And we are missing a whole bunch of those people. And when we do some analysis of that, what we learn is it's a combination of factors. Part of it is that these LVEF values are not always structured, so our system can't get at them. Often that's because these are referral patients, so they've got their systolic function in an external report. It has been reviewed, but we don't have documentation of that. Another possibility is an LVEF was recorded outside the time window of interest, and a provider may have reviewed it more recently, but there's no way to document the fact that they have reviewed it and discussed it with the patient. So we just can't get at that information. The system can't do it. So at this point, we've moved up this observed line by getting rid of all of the implementation problems that we can, but we're still not all the way up to matching the observed performance with the actual performance. So we still have this bridge that needs to be closed. So we need to improve documentation and the data-related problems, and we also need to start actually working on the actual performance. And in order to do that, we need an intervention. And that's where Anindita and her team came in.
So I came in the middle of this project, and I was told to improve the information system. So as Dr. Matt mentioned, we wanted to have standardized care across OHSU for heart failure patients, and wanted evidence-based guidelines to be followed for their treatment. And then the work that IDL had done, it showed there's a discrepancy between what's actually happening, like in the chart review shows it's a 90-something% that there's documentation, but when you do the automatic data extract and quality measures, it's much lower. So for us in clinical informatics, we follow the standard SDLC process of system development lifecycle of doing an analysis of what's currently there, what's the gap, and how do we get to our ideal state. So when we looked at the current process, we saw that it was data was being entered in as free text, which is not ideal for writing queries and logics and extracting the data. And a simple tool was being used called dot phrase. Now, I'm going to use a lot of EPIC terminology. I don't know whether you're familiar with it, but stop me if you need to know more. So from there, we needed to get to our vision of standardized care and evidence-based guidelines for these patients. And so we looked at what are the gaps. So the current tool had limited capability because it depended on the providers remembering to use it. It was not capturing all the discrete data elements that were needed for the quality measures. There was also a lack of standardized workflow for these kind of patients and guidelines for that. And we also didn't have any method for doing a decision support guidance for these patients. So in our planning phase, and I think this is very important, there was a lot of collaboration. Like Dr. Ahmad, he wanted everybody at OHSU, whether it's a specialist, other subspecialists, or primary care physicians, looking at it to follow the same guidelines. So heart failure has a best practice committee, which is a multidisciplinary committee. So that was a good platform to bring up these issues and discuss what the providers wanted. And also from our side, in informatics, we work very closely with the ITG group to develop the tools, and it took a whole team of people to develop what we needed. So next, I'll go over some of the tools that we built and why we built them to get to our endpoint. So one of the things is that we want this documentation tool to be available to all providers and take care of variations in practice, documentation practice, and the way the patient enters the system. I mean, the patient can be just inpatient or outpatient, and there are various differences. So we leveraged the use of the EPIC registry. So we created a database. We checked the inclusion rule and modified the inclusion rule to, maybe look at problem list and encounter diagnosis. These are the things that would take care of practice variation. And looked at the inpatient charts and outpatient to capture the data and have a database for heart failure population. So this registry was then used for making a documentation tool, in this case what EPIC calls a smart form, available to the providers when the patient is in the heart failure registry. So it captures discrete data, and that's where we plugged in all the data elements that were needed for the quality metrics. Next, we built a smart set. This is another way. This is a way to efficiently order some of the evidence-based medications that are needed for these patients. And for example, this is the feedback that we got from primary care, that having a smart set would really help them place those medication orders. So it's really important to talk to all the end users. We put in a best practice alert to remind the providers, hey, you need to fill out this form. It's important. Another piece that we did was the synopsis. Synopsis is a review tool, so while the provider was in the clinic, he could go back and look at the trend of how the class and the stage of the patient had changed over time, and other information. And to tie this all together in EPIC, what we have is a navigator. Navigator is it guides the workflow. So we put all these pieces in a navigator so that providers didn't have to click through various different things in EPIC to get to it and go through it smoothly. So next, I'm going to talk more in detail about the smartphone, a couple of the tools that we built and how it helps. So this is the smart form in EPIC, and I don't know how that 0 went in there. But so we try to make it as easy for the provider as possible. so that, and the providers don't like Epic and they don't like clicking. So we have this one button there, load patient's last saved values. That is, if someone else had already seen the patient, the provider could go click that, it would fill in all the previous values, and then he or she would only need to change the ones that had changed for that encounter. Then we also have some questions related to medication. For these, we put in the program so that it would auto-populate based on the medication list. And if the provider had already prescribed the medication, it would say yes, and only if it's a no would the provider need to go in and fill in the reasons why the medication was not appropriate for this patient. And the providers also developed documentation about the standard algorithms that need to be followed for these patients. So those blue links that you see, if you click on them, they tell you, the medication and the dosage and extra information that would help someone who's not very familiar with these kind of patients, what they need to do. So this is an example of a smart set. So here, as you can see, in the blue, we've written like some guidelines of when you should order or not order these medications, and some default dosages and standard dosages already pre-populated for these medications. So the provider just has to click that and order, and it'll be done quickly. So we did a whole bunch of stuff, as you can see, built a lot of tools and all sorts of fancy things, and now we want to know whether we really made a difference. So how do we know that? So I think Nicole will tell you, because she looked at the data, and you can see.
Okay. So this is a trend of the performance on one of the quality measures, and this is specifically the patient self-care education measure. And I know that was mentioned earlier as being particularly important. Patients' ability and knowledge to deal with their own care is especially predictive of outcomes. So up until this point, this was using the original clinical quality measure that we implemented using the existing data sources and before all of the interventions that were just described. This first line here is when the new tools went live specifically for the heart failure team. And you'll see that we split into two different lines there. And that blue one on the bottom, we kept running. That's using just the original data sources, so just the dot phrase. And the red one is using the dot phrase and the new data coming in from the smart form and the related tools. The second dashed red line is when this set of tools went live for all of cardiology. Not all of our figures look quite this nice, but I think that this is really a pretty impressive demonstration of the impact that you can have with health information technology when it is implemented in a really thoughtful way and is done with collaboration and input from a multidisciplinary team. And we expect that this blue line is going to keep trending downward even as the red one continues to go up as people use the dot phrase less and less frequently, and that gradually washes out of our measurement window. And the performance hasn't plateaued yet. We would like it to keep getting higher, and we're going to have to see what happens, especially as this tool becomes more broadly available. So we had a number of lessons learned in the course of doing this project. And if you guys want to pipe in for any of these, feel free. So I know Anandita made this point that we need collaboration between specialists and generalists at the provider level, and then also between providers and informaticians and other analysts. In order to really ensure that providers are going to engage with these tools and use them instead of this just being something that we dump out into the ether and it never gets used, requires a lot of feedback and focus on actually changing practice patterns. But the good news with all of this is you can actually optimize information systems to meet documentation needs. And I really want to emphasize this because a common complaint with electronic health records is that people just document and they document and they document, and that information is not presented to the providers in an actionable way a lot of the time. So the way, what Anandita was showing with the data that will populate from previous entry and kind of summarize the patient state right there at the point of care, that's really unique. And it's a really powerful tool. So again, we need to keep in mind the behavior of the end user when we're designing these tools. We also learned that validation and testing, even though they're incredibly time-consuming, this manual chart review takes a long time, it's very, very important for reliability and trustworthiness. And if the providers don't trust the data, if the stakeholders don't trust the data, then it's not worth very much. We also learned that ongoing maintenance is a resource drain, but really necessary. And if you were here for Adam Wright's presentation, he talked about how they would put in these clinical decision support systems that would suddenly break because something in the system changed somewhere. We have the same experience. We've had things that were, motoring along just fine, and then we look at the data and we're like, oh, something changed there. Someone changed a code or an Epic or something along those lines. And lastly, that tool choice and design impacts documentation. So you can change provider behavior. So we view this as a success. So we had the ultimate goal of improving clinical outcomes. We developed robust analytics tools and a reporting platform for clinical quality measurement. And it's too early to look at actual clinical outcomes, but we believe that we have improved evidence-based quality of care. We have leveraged the EHR to improve adherence to clinical guidelines. We think that this system reflects value-based purchasing. And we have emphasized cultural integration among providers and between providers and the rest of the people involved in this kind of effort. And we have a very, very large team that's involved in this work. Thank you, guys.
And so let me just remind everyone that when they ask a question to turn on the mic in front of them, just so the people who are listening and the recording will be able to hear it. It's a very interesting talk, and it reminds me why healthcare will never be as simple as an iPhone with all the complex data and interaction required. My question, and I think it's great to auto-populate forms, but sometimes, not necessarily in healthcare, but when forms get auto-populated, people might not pay enough attention. Kind of in the same way, when you copy and paste, you might not be paying attention to something has changed. Have there been any problems, or has that been an issue at all, or do people really pay close attention when you guys auto-populate?
Yeah, I mean, that's a great question. So much of this is just cultural behavior and documenting things, right? We haven't shown that this is improving clinical outcomes. This is improving our documentation of things beyond medications that were much easier to document. I'm sort of drinking the Kool-Aid, so it's hard for me. We get a lot of pushback from people like, well, I'm going to be penalized. They're like, this is not set up to be a penalty. This is set up based on what a society has said as 9 measures that we think are important for care. Because there's really no easy way to document that we had a discussion about whether or not a defibrillator was indicated. And there's so many codes out there, you can't necessarily pull out who has a defibrillator or not easily. What I personally, I can speak to my personal practice, what I found is that and admittedly I see a biased population that is sort of, in some sense, terminally differentiated in their therapeutic interventions. So when I copy forward, the most important thing to me is what is their functional classification. and have I addressed some big goal issues that I will document and dictate, but not necessarily discrete if I didn't have this. So I think what we're seeing is that, and I think we can try to go down and see how many people are clicking the copy forward, and then after you click the copy forward, are you then changing something? The beauty of the system is that everything is time-stamped, so you can actually measure time, and that's really an important thing too. So we haven't, I think, necessarily looked at that, but we can look at that. But I think from those of us in the heart failure group that are kind of living and breathing this a bit more, I don't think it's that onerous, and I don't think you run the risk of not addressing it. The problem with a lot of anything copying forward, we copy forward stuff ad nauseum every day here, and it doesn't get changed. And so from a quality standpoint or from a bucketed standpoint, it looks like we've checked the boxes, but we may not have addressed a large proportion of that, and there's no way to discern that really. But at least since everything's a discrete area, and once it gets clicked on, if I'm not mistaken, it's stamped. And so you can actually look to see how that has changed practice. I don't know if that answers your question.
About the medication. So the medication-related questions are looking at the medication list. So if the provider has prescribed, it's just pulling in that information. And then if you go back to the form, you'll see it's grayed out. That means the provider doesn't have to do anything. But then the ones which are no, it comes up with extra buttons of why, the provider has to fill in why the medication wasn't prescribed, and it's highlighted yellow, so it kind of indicates that you need to do why it wasn't prescribed, because that's tied into the quality metric where you have to have legitimate exceptions, exclusions to see that. So that helps, I think, to show that.
I was wondering if the team could speak to some of the challenges you faced as you went to change behavior based on the work that Anindita and team did, and how you address those challenges in terms of getting providers and medical assistants and so forth to actually use the tool?
Yeah, that's a great question. I think we're still early in the phase, and so it's hard to see how that changes behavior. So what we've done initially is there are 4 of us that focus in the heart failure clinic, and even amongst our group that this is what we do, there is variability between the 4 of us. And so what we're trying to do is give feedback reports to say this is not penalizing you, but here's where you are not documenting, and how does that change practice. An important thing about this is this tool is designed for really a subset of heart failure patients in some sense, those with a low ejection fraction. And we know that there's a lot of heart failure patients that have a normal ejection fraction or squeezing function of the heart, which have very few evidence-based therapies. And so and we didn't want to do 2 different smart forms. And so some people are saying, well, my patient falls out of this. And so we're but we designed this really for the bell curve, not the tails. The challenge with an academic medical center is we see lots of tails, right? We see a lot of the zebras, but we designed this for the horses. And culturally, that's how we're trying to change behavior a little bit. It's okay not to fill it out. You are not going to be, if you don't think it's germane to that. But I think it's still early in the phase of this rolling it out to try to change that behavior a little bit.
Actually, I had 2 questions. The first is the kind of hallmark case presented in terms of the effects with the patient self-care evaluation. I was curious exactly what led to that and why that certainly is an easier thing to assess, but somewhat different than the other kinds of assessments. The second question was regarding the structured capture. Right now, it looks like the NYHA class, 1, 2, 3, it will capture there the structured click the button, but I didn't see any areas that were capturing actually left ventricular ejection fraction or other areas that are actually granular data that feed into kind of the way to think about heart failure. I wonder if there's any effort to kind of be able to collect that sort of information as well and use that to segregate which people that get which work, et cetera.
Yeah, that's a great question. So this whole task could not have happened in some sense without one number, ejection fraction. So for years, when we would read cardiac ultrasounds in the echo lab, we would make a PDF, and it would get scanned into EPIC. And there was no discrete bucket for an EF. So Dr. Heitner, in his efforts at the Echo Lab, was able finally to make ejection fraction a discrete number in results review. And you can see it's up here, the last ejection fraction. So, which is not part of some of those measures, but we thought it was very important. So it is up there. And so it's auto-populated from the last echocardiogram that has been bucketed into the results review. If we didn't have echo in the system, this would have been a lot harder to identify patients with an ejection fraction of less than or equal to 40%, for which all these evidence-based therapies are recommended. So that patch, from a system standpoint and from really just the two systems talking to each other, was really important. There's lots of data streams in this hospital every day where the two systems are different vendors and they don't talk. You know, everybody's trying to get patched into Epic, but we still have, every single pacemaker we have does not talk to Epic, right? And so what we do now is we scan printed things into Epic, and Echo is the same thing. Your first question was about? Yeah, right, so a lot of those things are they taking a certain pill, what's their class, what's their stage. Self-care is really important, but that was something that was not discretely identified. That's just one thing we pulled out, but I think you could pull almost outside of medication, so presence or absence of a defibrillator would be another one that would show similarity, because that was not something that was easy to pull from the system. The medicines were always easy to pull from the system. We were not routinely documenting stage, documenting New York Heart Association class, right? My class 2 could be somebody else's class 3 and vice versa. Now we can see over time, how does that functional class assessment change? How do their medication dosages change? How do their medication prescriptions change? We don't have that level of data until now.
One thing that Dr. Mudd was just getting at is, you know, we've been talking about these performance rates, which is just one view of the data that are being captured at this point. You know, this also allows you to, we could do analytics on different patients to show how they're doing using all of these data. So it's not just about overall performance based on these guidelines, but the availability of those data more generally.
Yeah, and I think we can, it's not per patient, it's per provider group. It's, you know, if you had it in the hospital, which floors are doing better, which are doing differently? What are the system barriers to try to not only document, but then also ensure the next step is going beyond documentation and ensuring that the therapies are actually being delivered, the patients are actually taking the medications. We're actually following up and doing the due diligence on the other end. So this is just a start. At least we can now measure that initial bucketing of the data.